Hello viewers, welcome to this episode of Healthy India. Today we'll be discussing breast cancer. Why breast cancer? Breast cancer is probably the commonest cancer in the world. The WHO says that in 2020 alone, there were 23 lakh cases diagnosed with breast cancer. Also, it's an area which has seen considerable progress, huge advancement in treatment. And the overall outcomes of disease have improved a lot in the last 3 or 4 decades. And also, in March, we celebrate International Women's Day on the 8th. So I think it's a good opportunity to discuss all modern findings and details about breast cancer. So whatever improvements have taken place in management of breast cancer have actually been related to 3 different specialties which come together to help our patients. The surgeon, the radiation therapist, and the chemotherapist. So, we call them medical oncologist, surgical oncologist, radiation oncologist. And to answer all our queries about breast cancer, today we have a panel of experts comprising all 3. To my extreme left is Dr. Atul Batra, who is an associate professor in medical oncology at the All India Institute of Medical Sciences, New Delhi. We all know about AIIMS, needs no introduction. Dr. Geeta Kadayaprath, who is the surgeon here, senior director, breast and surgical oncology at Max Hospitals, Patparganj, Vaishali, and Noida. And nothing is complete without radiation. And for that, we have Dr. Kanika Sood Sharma, who is director of radiation oncology at the Dharamshila Narayana Hospital, Delhi. Thank you, all of you, for being here. And without wasting any time, I'll plunge straight into the topic. So we all read that breast cancer is the commonest of all cancers. What is the scenario in India about breast cancer in terms of its epidemiology, its prevalence, incidence, etc.?
Yeah. So if we look at the numbers that are given by ICMR, so there's a National Cancer Registry program that looks at the numbers of cancers that are diagnosed annually as well as the prevalence. And there are hospital-based registries and there are population-based registries. So if you look at the latest data, that tells us that in India, a total of around 15 lakh cases of cancer are diagnosed annually. And the number has been rising constantly. So the latest numbers are between 14 and 15 lakhs. So to give you an idea of how breast cancer comprises of this number, it is around 2 lakhs. So
2 lakhs of fresh breast cancer cases diagnosed every year, typically.
Yeah. So if you look at the numbers, this has gradually now replaced cervical cancer that used to be the most common cancer in women. So if you look at, actually it is the most common cancer even if we include men.
Yes.
So it alone, every 7th cancer would be breast cancer.
Wow.
Now, there's a difference in the distribution of breast cancer incidence amongst India. Like as we say, India is a multi-countries within a country. So the incidence varies a lot between the metropolitan cities where the incidence is highest. So if you look at Delhi, Hyderabad, Chennai, Mumbai, Bangalore, these have higher incidence of breast cancer. And when we compare this data with rural registries, there it is much lower. But they are also picking up. So there could be a multitude of factors, increased awareness, lifestyle changes. So there are a lot of factors that are different between these 2 areas.
So, very important point you made, and when I started my career in medicine, we were always told that genital cancers are the ones that are common in India and breast cancers are the ones that are common in the West. I mean, as a general, and what you're saying is very clearly then in some way linked to lifestyle and the risk factors that people have to face now, because something has changed in breast cancer. Of course, some of it is obviously earlier diagnosis, but it's not just that. So I'd like Dr. Geeta to explain to us who are the people at risk for breast cancer and what could have changed. I mean, how do risk factors modifiable risk factors influence the onset of cancer?
So you're right, if you ask for a cause for breast cancer, you will not find one. But if you were to look at breast cancer, you have to talk of risk factors. But if you look at our Indian population, in fact, you will not find all those risk factors. So I will not touch upon the non-modifiable risk factors because that's something you cannot change. But I always say that the biggest risk factor is the fact that you are a woman is the biggest risk factor. And other than that, you know, things like you said, it is a lifestyle disease. So the fact that we are on the fast lane, wanting to match our careers with our age, it doesn't work out like that. So you don't have your kids on time. Women find it difficult to breastfeed because that would mean confining them to the homes. Then things like physical activity and what you eat are all risk factors in the sense that if you do not put in enough physical activity, and if you do not eat right, because obesity is the other epidemic that we talk about, and obesity has been, in fact, it is touted as one of the most important risk factors for almost all cancers. So these are the modifiable risk factors that we're looking at and finding it tough to, you know, get rid of.
Does age at menarche and menopause, do those things make any difference?
So those are non-modifiable. You cannot change it. So yeah, early menarche, late menopause,
yes,
longer period of exposure to hormones. And so that is the reason why it is an important risk factor as well.
So we come to you, Dr. Kanika, and you know, we're talking about the disease going up in India, possibly some of it modifiable, but how do we find out? What do we tell our patients? What do we tell public? That, you know, you need to be aware about breast cancer or the risk of breast cancer. What should somebody do about that? And what screening or basic tests should be carried out in a normal, healthy woman?
So I think early detection is the key, and it is the cornerstone to success for any cancer, leave aside breast cancer. So what we need to endorse to our public is annual health checkups. And during those checkups, you are likely to pick up many diseases which may not be apparent. And if I talk of breast cancer, I think we have a tool which can be employed for screening, which is the mammography, which any woman who's aged more than 45 years can start annually and go on up to 45 years of age. Thereafter, so maybe once in 2 years.
45 to?
54. 54 annually.
Okay.
Then after that, she can go every 2 years if she's an average risk patient. In case there are higher risks by virtue of her genetic history or other factors ma'am talked about, then she can go on doing it annually up to the age of 75 or till the time we deem that she has a reasonable life expectancy left after that. And the other thing which can supplement apart from the mammography is educating the people to do self-breast examination. If a woman is doing self-breast examination on a monthly basis, she will pick up symptoms like she's likely to pick up lumps in the breast or in the axilla or behind the collarbone, changes in the nipple, any nipple discharge, which she would be aware if she's knowing how her normal breast looks like. So that is something which still holds value, I think, in our country. The third thing which I think which aids the health checkup is the clinical breast examination. So if a person is coming for a health checkup, it gives an opportunity for the clinician to examine her. So if a woman keeps meeting a doctor for an examination every 2 years after 30 years of her age, and then maybe every year after 40 years of age, that gives an ample opportunity to detect these tumors very early when they are under the preview of a cure.
So what Dr. Kanika is telling us that women should have an annual breast examination after the age of 45. A regular self-examination of breast, whatever may be its pitfalls, still might help. But an annual breast examination by a trained clinician is very helpful in detecting early breast cancer. You also said that you do recommend annual mammographies. So some people say that we shouldn't do them annually, should do them every 2 years. There's a bit of always a bit of a controversy there. And there's also this question about radiation and mammography. Should we do that? And I'll throw the third one in here also. What do you think of ultrasounds? Are ultrasounds of any use in screening because they have no radiation and, you know, non-invasive again?
So apart from mammography, the concerns you raised, there is a valid concern in many cases. Apart from mammography, ultrasound does hold value, and particularly the younger ladies where mammography sometimes may not give you much of information. Ultrasound is a very good tool for screening. Apart from ultrasound, MRI also has some value in terms of screening, but understanding
Not
the cost
possible,
effectiveness,
yeah.
it is not something we could do, and it has its own share of
Right.
pitfalls. You know, we
Yes.
would be overdiagnosing certain conditions which
Right.
might not be cancerous, and unnecessarily will expose these women to biopsies and FNACs. So the norm is a mammography, and in situations, ultrasound may aid to the mammography findings or may be independently used as a tool in the younger women.
So there was some controversy about breast self-examination. Geeta, what do you think about breast self-examination? Because I was checking, and many countries are not recommending it now. And why? And I think most of our colleagues say that yes, it is important in India.
So if you ask me, so you know, we should not be comparing ourselves to the West at all times, because the West has a very definite, well-defined screening protocol, and they have the money to, you know, fund these screening programs. And in our country, we do not have a screening protocol, and even if we do, we cannot reach to the last woman standing. So we have to take our lives in our own hands, literally, because I think breast self-examination is all about feeling your own breasts. And the trouble with our countries, even today, breast cancers come in advanced stages in about 60 to 70% of cases. So if one were to get familiar with one's breast, obviously, you know, somebody would have come in stage 4 would possibly land up coming in stage 2, and somebody in a stage 3 can be down stage to a stage 1. So we want to catch them early. So for us, I think early diagnosis is the key.
Is the key, and self-examination is still recommended
Yes,
by most of
absolutely.
us. So Atul, I'd just like to ask you, we move ahead now. Okay, we think this should be detected early. We are, let's say, in an ideal situation, doing everything that we can to detect it early. But then that is only suspicion, right? How do we move ahead? How do we confirm a diagnosis?
So a typical lady, if we look at with a suspicious breast cancer, would present with a breast lump with or without other features, right? First investigation would be a mammogram, right? If the patient hasn't been detected on a screening mammogram, which is not the usual case here, the first investigation would be a mammogram. We want to characterize what kind of a lump is it looking at. Is it showing like a more chances of a malignancy, or is it looking like a more like a benign thing? So there are categories within the mammogram that we call as BIRADS 1, 2, 3, 4, 5, higher the number, higher the risk. So if you have a suspicious lump on mammogram, say it is BIRADS 5, which says that probably 95% of those would be malignant. Then the next step would be a biopsy. Why a biopsy? Why not an FNAC when FNAC is less painful with a thinner needle? FNAC will basically take out some cells, right? Very few cells. A biopsy would take out a small tissue out of it. Now we have to understand that breast cancer is not one disease. This is kind of the main message, and this is the main reason that we have progressed over the last 15-20 years, because we understood that breast cancer is a heterogeneous disease. Broadly, it is of 3 types. The most common one is a hormone-dependent disease, which is dependent on estrogen and progesterone of the female hormones. This comprises around 60-70% of the cases. The second one is a HER2-positive disease, which is around 15 to 20%. The rest is triple negative, again 15 to 20%, a little higher in India because we are younger. So these 3 are managed differently upfront. Even if it is a small tumor, we may like to give chemotherapy for as small as 1 centimeter of tumor if it is a HER2 positive or triple negative tumor.
So therefore, a biopsy confirmation is very important. You're talking of an FNAC or an actual biopsy, or just remove the lump and biopsy?
A biopsy, needle biopsy.
Needle biopsy.
Yeah,
Okay.
it is very important to know what kind of a tumor are we dealing with. It's not just breast cancer. Is it a triple negative cancer? Is it a hormone positive cancer? I know these are some technical terms that I didn't want to throw out, but without knowing the basis, it is very difficult to understand why do you want to poke in a larger
define the variety, the type of cancer, so that appropriate medical treatment can be initiated. The role of chemo versus radiation versus surgery will be determined by that. Therefore, a biopsy is very important.
Absolutely.
And a biopsy does not cause the cancer to spread.
Absolutely. That should be
I'm just saying it before.
Yeah, this is the most
you
common
say it.
question.
Yes, yes. So I think we need to understand that screening is very important. We also need to understand that the confirmation of diagnosis will be by biopsy. And please do not shy away from that. If your doctor advises you a biopsy for a breast lump, please go ahead and get it done as soon as possible. We'll take a short break here and be back with more. Welcome back after the break, and we move to our surgeon, Dr. Geeta. Dr. Geeta, we have initiated screening. We discussed that. We found some suspicious lump there. We've gone and gotten a biopsy done, and the diagnosis is confirmed. Now, does everyone with breast cancer need surgery always? And what does surgery for breast cancer mean?
So surgery is a very, very important part of the treatment of breast cancer. And just as Dr. Atul said, the sequencing can be different. You could possibly start with chemotherapy and then go on to surgery. But surgery is a cornerstone of treatment of breast cancer even today. What has changed is that it does not necessarily have to be a breast removal surgery. So it is amenable. Most of the lumps, especially the smaller lumps, are amenable to breast conservation surgery upfront. And if they are not, and if the patient is still desirous of a breast conservation, the medical oncologist can help us reduce the tumor to a size when it becomes possible to conserve. And not just that, a conserved breast does not have to look ugly anymore. You can apply oncoplastic procedures wherein you remove tissue from around the breast or within the breast to make it look complete and as beautiful as it was before.
I think those are very, very important and very encouraging points for our patients and for the public, that surgery for breast cancer is not necessarily mutilating. Often surgery can preserve your breast, and there are techniques to build the breast after that also. So really one should not get overwhelmed by the fact that you may have to undergo surgery either before or after chemotherapy. But there's another aspect which is very important in treating breast cancer, in all oncology for that matter, and that is radiation. So where does radiation fit into all this? Because another thing, people are scared of all three modalities of treatment. The common psychology is obviously no one likes to go for radiation. So tell us a little bit about radiation in the context of breast cancer, and has it really improved over the years?
So as ma'am said, that breast conservation is something which is the order of the day if feasible. So radiation remains an integral part of treatment if breast conservation has been done. Apart from that, if mastectomy has been done, any tumor which is more than 5 centimeter or node positive would require radiation. So there would be almost 60% of our patients who would be coming to us for radiation. And as you rightly said, people fear radiation. Radiation jala deti hai, sikai hai. So these are the fears, which are in people's mind when they come to me for radiation. So radiation in today's era is very, very modernized. It is targeted. It is delivered exactly to the area which we want to treat. So we have armamentarium to protect the innocent organs like the heart, the lung, and skin as well. So like if a surgeon has done a beautiful surgery, the radiation oncologist's duty becomes that we maintain that cosmesis by giving a radiation which does not affect the skin tissue badly. So we have means now to address these factors, and definitely the era of radiation we live in is much different from what it was.
So that's an area where there have been considerable advances. Of course, in all areas in oncology, there's been a huge change. As you said, surgery, you can conserve the breast in many cases. It's not necessarily so mutilating, doesn't look that bad, and will cure disease, perhaps. And radiation techniques have improved exponentially, actually, to reduce the risk of damage to surrounding tissues and target the tumor itself. And the other area, again, which everyone is always concerned, is about chemotherapy. So do all patients with breast cancer require chemotherapy, or how does it work for breast cancer?
Yeah, so I think again we'll build up on our previous discussion that breast cancer is not a single disease, and there are several types of breast cancer. Not every patient would, of course, require chemotherapy. With advances in understanding what the breast cancer is dependent on, we have understood that most of the breast cancer are actually dependent on the hormones. And if such tumors are diagnosed very early, they may not require chemotherapy. Hormone therapy might be sufficient for them. There's no advantage of actually giving chemotherapy. On the other hand, there are some tumors that even if they are small, 1 centimeter, like I mentioned, triple negative, they would require chemotherapy. And HER2 positive tumors, they require something called as targeted therapy. So these advancements have actually helped us individualize the treatment, what to give, how to individualize, what is the best sequence. So that is why now we require all three of us to sit together, discuss what is needed and what would be the best sequence. So it has become actually quite complex to make such decisions with the patient also respecting her decision, what
Yes.
she wants.
Yes.
That is the most important.
I think that's a very, very important point, and I'm so glad you raised that, because nowadays patient involvement in their own treatment is very, very important. It's actually unethical not to involve the patient in their own treatment. And I'm so glad that we are discussing this today. Obviously, one thing that comes out of the discussion is that treating a patient with breast cancer requires multiple specialties. And they're all part of one specialty in some sense, because they're part of oncology. At the same time, different skill sets are required. And that it is a combination of these skill sets, along with technical advances, that has resulted in so much improvement in outcomes of breast cancer. And some data suggests that there is a 40% improvement in outcomes of breast cancer over the last few decades, especially in the more developed countries, simply because of optimum screening, early diagnosis, and proper treatment. So, Dr. Geeta, whenever the big C is discussed, people fear the worst. So, is breast cancer curable? What is the outcome of breast cancer?
So I would think, yes, a lot has changed. Like you said, especially in the past 2 decades, so much has changed. And I'm sure Dr. Atul would stand testimony to this, that, there are so many new drugs and new treatments that are coming in, which is, adding incremental benefit to whatever we had achieved so far. So if somebody were to say yes, I would say early stage breast cancers are eminently curable. So the onus is on the people, on the women, that they should familiarize themselves with their breast, go for screening if they can, and catch disease early, because early disease is what is going to translate into good outcomes. And now with the targeted therapy that Dr. Atul was speaking, I think it's been a revolution in the treatment of breast cancer. We're seeing very good results with targeted treatment and now immunotherapy and a lot of other things that have come into the armamentarium of the medical oncologists. So I think we are looking at potential cure for a lot of women who are caught early.
So we do know a lot about breast cancer survivors. We all have patients, plenty of patients who are breast cancer survivors. And so what is the proportion of people, let's say those who are diagnosed early at the moment in our kind of environment, what proportion would have a disease-free life after a few years of proper treatment?
So if you were to club stage 1 and stage 2 together, we would think, and they've had optimum treatment, you would expect about 70 to 80% of them to go past 5 years.
That's fantastic.
Which is good, which is excellent, which is something very different to what we were seeing earlier.
So there's a lot of, not only has the cancer become common, but its treatments have improved vastly.
Yes.
So while it has become common, we can also do much more about it with some awareness and, and some. So before I come to the end, I would like to ask you one question. People are always concerned about side effects of chemotherapy. Efficacy of chemotherapy has undoubtedly improved with newer therapies. Do you think that the side effect profile has also improved?
So I think if we talk about individual chemotherapy agents, we are still, I think the backbone still remains the same chemotherapeutic agents. But now choosing patients who do not require chemotherapy has helped us decreasing the overall side effects.
Yes.
So now side effects are avoided in those females. And if we talk about HER2 positive tumors, there I think a lot has been improved because targeted therapy doesn't have much side effects.
Okay.
Right? So there some chemotherapy agents can be avoided. We now know much more about chemotherapy agents, like what is the maximum dose that can be given, what is the best schedule that would be suitable for the patient, which would have lower side effects. So that has improved, right? And many patients would require just hormone therapy that has very few side effects as compared to chemotherapy.
Fantastic. All good news coming in here. And the most important, one is survival, outcomes, secondaries, recurrence, metastasis. What about quality of life, Dr. Kanika? Do these women, do our friends, our patients who do fall prey to, breast cancer in the sense that they get the disease, what is their quality of life? Even if they survive, supposing you survive, and you're bedridden and you can't move around and you're sick, that may add to survival, but that's not quality of life. So is their quality of life good? Is it better?
I think I'll add on to what my previous panelists have spoken, that there is a difference in what we used to do a couple of decades back. So the goals of oncology have changed. It is beyond overall survivals and progression-free survivals. We talk of a new goal, that is quality of life.
Yes.
And I think the tremendous contribution in this quality of life has come from the fact that we have come to an era of minimalism. Surgeries have moved from halsteadians to the breast-conserving ones.
Yes.
Instead of axillary dissections, we are doing sentinels.
Yes.
Chemo has become more selective and judicious in approach.
Yes.
So is radiation. So we are trying to find out people who we can avoid giving certain treatments.
Yes.
So now it is the era of less is more. So we are judiciously selecting. And then whatever we are giving is more targeted. If I talk of radiation, we are cognizant that if this woman lives for 30 years, she might have cardiac effects. So all these are accounted for and our techniques are taking care of them. So quality of life definitely has improved. And I think Dr. Geeta will endorse the fact that now these survivors are becoming ambassadors and showcasing that there is much more to look at after cancer. They are showing that life or the beauty doesn't end with cancer. So quality of life has improved. But having said that, it is the stage at which the patient comes to us. As you rightly said, if somebody comes in stage 4 and you do not have much to contribute, that is the, in essence of this talk. We don't want that more people come to us in that stage, and we would love to treat patients early to give them good life.
Well, thank you very much. देखिए, हमारे विशेषज्ञों ने क्या बताया? हमको ये बताया कि ब्रेस्ट कैंसर इंडिया में बढ़ रहा है, दुनिया में बढ़ रहा है, इंडिया में भी बढ़ गया है बहुत, शहरों में ज़्यादा है, गाँव के मुकाबले. इसका अर्ली डायग्नोसिस अब पॉसिबल है अगर हम केयरफुल रहेंगे, सावधान रहेंगे, ब्रेस्ट एग्जामिनेशन करेंगे. जो 45 के ऊपर वाली महिलाएं हैं वो समय समय पर मैमोग्राफी या दूसरी जांच कराती रहेंगी, जिससे कि जल्दी ब्रेस्ट कैंसर को पकड़ा जा सके. कोई भी ब्रेस्ट में गांठ हो उसकी जांच हो, उसके लिए जो भी इमेजिंग की जांच में जो एक्सरे वगैरह होने वो हो, अगर बायोप्सी होनी है तो बायोप्सी हो. अगर वो कैंसर निकलता है तो अर्ली स्टेज पे ट्रीटमेंट बहुत सक्सेसफुल होता है. और इसलिए इससे भागना नहीं है, रिस्क फैक्टर्स अवॉइड करने. रिस्क फैक्टर्स माने ओबेसिटी को अवॉइड करना है, लाइफस्टाइल को अच्छा रखना है, जो हम आपको इस प्रोग्राम में बहुत बार बता चुके हैं. वो चीज़ें ठीक रखें, रेगुलर स्क्रीनिंग रखें. अगर आप वो ध्यान रखेंगे तो अगर ब्रेस्ट कैंसर हो भी जाता है तो अर्ली डायग्नोसिस से आजकल आउटकम बहुत अच्छा है उसका, तो उससे घबराना नहीं है. ऑन्कोलॉजी में बहुत एडवांसेस हुए हैं जिससे ऐसे पेशेंट्स, अब आपने देखा भी होगा, बहुत प्रोग्राम्स आते हैं ब्रेस्ट कैंसर पे. देयर इज अ डे ऑल्सो ऑन दैट. देयर इज लॉट ऑफ पीपल हु आर पिंक रिबन्स एंड ब्रेस्ट कैंसर, लॉट ऑफ अवेयरनेस. तो ये अवेयरनेस बहुत ज़रूरी है और इसीलिए ये प्रोग्राम किया जा रहा है कि सब महिलाएं इस बात का ख्याल करें. आप सबका बहुत बहुत धन्यवाद. थैंक यू वेरी मच.
Thank you.